So we'll move along to our final speaker. It's my pleasure to introduce Dr. Davide Momi. Davide is a postdoctoral fellow at Stanford University in the lab of Nolan Williams and working with Manish Sagar. Prior to that, he was visiting postdoc in Stanford with Corey Keller, and prior to that, in my group in Toronto for a number of years at Center for Addiction and Mental Health. So, Davide, take it away.
Thanks a lot for the introduction, and thanks for being here. So today I'm going to talk about how we can use whole brain model of brain stimulation in a clinical setting, and specifically working with MDD patients. So first of all, major depressive disorder is very diffuse across worldwide, and 30% of patients are treatment resistant, so they don't respond to any pharmacological treatment. And non-invasive brain stimulation, and specifically TMS, like a repetitive TMS in this case, is quite an efficient method for treating those patients. And specifically, they have shown like a very good percentage in amount of responder and not responder as well. So in the neuroimaging community, there were very good work on try to predict basically patients that respond and patients that don't respond from the treatment. And also like Robin Cash is in the room. One of his studies basically show how we can use functional connectivity, and specifically the negative correlation between SGACC and DLPFC to predict patients that respond and not respond from the treatment. And also in the fields of TMS-EG, we can use the so-called TP, so the TMS evoked potential, to predict the clinical outcome. And specifically in some study, we found like a decrease in N100 amplitude, and other like contribution have shown that we can use also other evoked potential in order to predict the clinical outcome. So every study that I show you, it's amazing, and it provides like a very good like overview on how we can predict the clinical outcome. In the lab that I'm working on right now, we have like a specific protocol, which is the SAINS. It's a high dosage protocol that has shown like very good remission rate in patients, and we are basically like working on TMS-EG measure, and we found that the amplitude of the response across the days is kind of predicting the clinical outcome, and is correlating. And when the patients transition to these states, is basically correlated with the response to the treatment. So every study that I show you, is great, but it's kind of limited by the fact that there is, first of all, high variability in the literature in the way that we can predict responder and not responder. And also those techniques are limited, like some have a spatial, low spatial resolution, someone has a lower temporal resolution, and also like it's very cost effective, especially when it comes to neuroimaging, fMRI, on diffusion in general. So all brain model and computational model can be a solution to all these limitations, and there are a lot of study literature that's shown how we can use all brain model or brain stimulation to predict other pathologies trajectory, for example, Alzheimer's disease, or like epilepsy, as I've been shown before, or like disorder of consciousness, but many other. So what is whole brain model? So for those who are not familiar with it, so we want to model, so this is just an overview of all the possible computational model that we can have. So we are basically located here, so we want to model activity at the level of whole brain, and specifically large-scale network dynamic. So for this, we use this framework, which I'm going to guide you through. So basically, we, from one side, I've shown also before, we have like the empirical data, and specifically neuroimaging data, structural MRI, or we can divide the brain in different nodes and parcels. In every of these parcels, we put like a computational model, and with this model, we are able to simulate the activity. And then we basically compare this simulation with the ground truth. It can be like a resting state fMRI EEG, and during the fitting process, we optimize the parameters in order to get like a good fit between the simulation and the ground truth. So in previous work, we have shown how we can use this whole brain model of brain stimulation to either predict whether a given evoked potential is due to a local echo or like a network reverberation, and also we found we demonstrate how different networks have different strategy for receiving, integrating, and sending information across the brain. The question that we have in this study is that can we use the model to predict patients that respond and not respond from the treatment? So in order to do that, we use like this data set when we have 90 patients with MDD, and we did like a clinical assessment pre-iTBS and also like a single pulse TMS EEG over DLPFC. Then there were like 6 weeks of iTBS treatment, and then the follow-up, so post-iTBS visit, which is similar to exactly the same as the pre-iTBS therapy visit. So for the model, we use the Janssen and Rit, which is basically a physiological model when we have like a pyramidal cell, excitatory interneuron, inhibitory interneuron. This model has been developed originally by Janssen and Rit for simulating alpha oscillation in the occipital cortex. We employ also like this model in the previous study, and specifically we use this term to inject an internal input for mimicking like brain stimulation. So this is the framework. So this is the model. Those are the data. So the TMS EEG data over DLPFC. You see like a resting state at 0, there is the perturbation by TMS, and we have the so-called evoked potential. So we put this model in a 200 parcel. So we divide the brain in 200 nodes, and the connectivity between nodes has been modeled via the diffusion. With this, we were able to simulate the activity at the level of the parcel, and then we invert the model to get the first simulation of the TMS EEG data. As you can see, like from the first iteration, the fitting between these two entities was not like good, so we cast the differential equation that I showed you in the previous slide in a PyTorch environment, and we use an optimizer for computing the loss, the gradients, and optimizing the parameter of the model. And finally, after a few iterations, we come up with a fitted TMS EEG time series, which was resembled the empirical one. So with this framework, so first empirically, from simply analyzing the empirical data, what we found a decrease like in this frequency range for comparing not responder minus not responder and post minus pre iTBS treatment. And with the model, we found that the amount of these changes, which was basically predicting a responder and not responder, was correlated with the amount of inhibition. And specifically, the more inhibition there was after the treatment, the more the patients will show this feature that was predicting the clinical outcome. So we take with the model, what we can do, we took this parameter, and specifically one patient's brain. So this is one patient's brain, and this is the time series, the simulation with the standard inhibition. With the model, we can tweak the parameter, and specifically we can increase inhibition by 10%, 30% or 50%, and show how basically this affect the evoked potential. And you see like reduction in the ATP. Interestingly enough, this was also like what has been shown in literature, but also like in the empirical data. And specifically, we found that if we take the global mean field average of the signal, we found like a decrease in the amplitude for responder post-iTBS treatment. This has been also like shown in literature, as I showed you before, like by some study by the group of in Toronto. And interesting enough, with the model, we can find the same feature, and specifically if we take the parameters that is predicting the clinical outcome, and we increase the inhibition of 10%, 30%, or 50%, we are able to kind of mimicking what's actually happening in the empirical data with a decrease in the amplitude of the response. Finally, we can, with the model I show you, we can also like simulate, the activity at the level of whole brain, and specifically we have 200 parcel. We can use basically those time series and predict, okay, tell me and say to the model, tell me what state predict responder and not responder. And those are the states that was significantly predicting and differentiate between responder and not responder pre-treatment. Interesting enough, we found that the direction of the SGACC and the LPFC of those was going in the opposite direction, and was kind of, mimicking what other forces like Robin Cash group have shown, like in the fMRI community, when basically the anti-correlation between SGACC and the LPFC is predicting the clinical outcome. So we can take these states and put it like in what we call, like in physical system, in a subspace, and show how basically these states evolve as a function of the perturbation. And specifically, this is what I'm going to show you in this movie. So we did that for the pre-iTBS treatment and post-iTBS treatment for responder in green and not responder. So you see how the system is evolving as a function of the perturbation, and you see that before the treatment, that basically there is no difference between the not responder and not responder in this brain state evolution, and after the treatment you will see a decreasing, like in the how much basically this trajectory are traveling for only the responder. I'm gonna give you basically a screenshot of the movie that I showed you before. Again, this is pre-treatment iTBS, and this is post-iTBS. You will see a difference for responder and not responder. And this is just a future direction for, say that, we will love to be able to basically run this model ideally online so that we can optimize the state that is promoting, the best clinical outcome, and, in order to provide basically a better therapy for these patients. With this being said, I'm just gonna summarize what I show you today. So first of all, I show you that, from an empirical point of view, we found a significant power decrease in this frequency range for responder post-treatment. And the amount of these changes was correlated with the amount of inhibition, in a way that the more inhibition, the more the patient was showing this feature. And then I show you how we can, with the whole brain model of brain stimulation, we can tweak this parameter in a way that we can resemble feature that we can find also like in the empirical data. And finally, I show you that the interaction between the DLPFC and SGC is also like predicting the treatment responder. With this being said, I say that I will also have a poster on Friday of the work that I'm doing at Stanford with the Nolan-Williams clinical trial and TMS-EEG measure, and we are also like planning to introduce some modeling down the line. And everything that I show you, it's on GitHub. This is the bioarchive, and this is the code for replicating the results that I show you today. And with this being said, I just want to say a huge thank you to all the people that contribute to the study, and also like to my group. Thanks a lot for the time.